I'll be presenting the case of Mr. XYZ, a 40-year-old male, daily laborer, hailing from Kolkata and currently residing at Kadagodi, belonging to the lower middle class of B.G. Prasad. The informant was himself and the information was reliable. He was examined on 31st of August 2020. He came with the chief complaints of deviation of mouth to the right side since 3 days, with slurring of speech since 3 days, and difficulty to completely close the eyes since 3 days. Coming to the history of presenting illness, the patient, who's a right-handed individual, was apparently all right 3 days ago in his usual state of health, performing daily activities, when he suddenly noticed deviation of the mouth to the right upon waking up at 8 a.m. from sleep. From the previous day, when he was completely all right while going to bed. Following this, the patient noticed weakness over the face, such that the patient had dribbling of saliva from the left side of the mouth while brushing teeth and was unable to completely hold the water in the mouth since then. This weakness has remained the same throughout 3 days, with no increase or decrease with any of the activities. The patient also noticed difficulty in speaking, such that he felt there was a slurring of his speech on uttering words like Papa, Pappu, etc., with no other difficulty in understanding, naming, reading, writing, repeating words. He also noticed no change in the voice or pitch of the speech, and this has remained the same since 3 days with no improvement whatsoever. Patient has also noticed inability to completely close the left eye since 3 days, which was acute in onset, which is non-progressive non-progressive since the onset, and he had noticed that while he went to sleep. However, he did not appreciate any increased tearing from the eyes or reduced sensation over the face. For these above complaints, the patient was taken to a local practitioner and was told to have a nerve problem and was started on medications, oral medications. There is no history of blurring of vision, double vision, increased or reduced hearing, change in voice or loss of taste that the patient complained of. There is no history of motor weakness of either the upper limb or lower limb. There is no history of reduced sensations over the face or body. There is no history of cerebellar symptoms like giddiness, vomiting, headache, swaying while walking. There is no history of recent fever or myalgia preceding these episodes. There is no history of ear pain, ear discharge, fullness in the ear or reduced hearing. There is no history of trauma or facial swelling that patient had noticed. Coming to the past history, there is no history of similar complaints in the past. He is a known case of type 2 diabetes mellitus since 3 years on regular oral medications and has been on frequent follow-up with his practitioner. He is not a known case of hypertension, tuberculosis, asthma, or any seizure disorder. There is no history of similar complaints in the family. There is no family history of type 2 diabetes, hypertension, asthma, or seizure disorder. The patient consumes a mixed diet with non-vegetarian food weekly thrice. Appetite has been normal. There is no change in the pattern of sleep that the patient has noticed. The bowel and bladder habits have been regular. He denies any deleterious habits or high-risk behaviors. Drug history has been on oral metformin since 3 years, and since 3 days he was started on oral prednisolone 40 mg every day. Coming to the summary of my case, we have a middle-aged right-handed gentleman with background history of type 2 diabetes mellitus, probably well controlled, presenting with acute onset of deviation of the mouth and slurring of speech with associated inability to close the eyes, with no sensory motor or cerebellar involvement or other cranial nerve involvement. So I would like to initially think of the lesion at the level of the cranial nerve, and because there is some difficulty in closing the eye, I would like to think of a lower motor neuron kind of a facial palsy.
Okay. We will analyze the symptoms. Of course, as you know, this is a very straightforward case, but we'll try to learn symptom analysis as we already always done. You know that 100ness. No? How did you? What score did you use? In the first class, we found we discussed the points by which we decide the 100ness.
Yes, ma'am.
So in this case, what are the parameters you use for those who were not there in the previous sessions? Now they can see how what scores you used as a revision. We will do.
Yes, ma'am. So handedness, we can test by the bedside ways is using the illuminoscope. Ask the patient to use the illuminoscope to look at the beam of light, and whichever hand is being used, so that hemisphere would be dominant, ma'am.
Whichever eye, because handedness goes with eyedness.
Whichever eye he uses.
So if you fix with the right eye, you are a right-handed person. Okay. What else? So handedness goes with eyedness. That is one point you might have used. Second,
along with that, clinging of the hands together and thumb, whichever is lower, whichever thumb is lower, that would be the
dominant. Down is dominant.
Down is dominant.
So that is the second point. Then
Edinburgh's handedness inventory, which can be either the bedside or research inventory.
Yes. So Edinburgh's handedness inventory can be applied if you are doing a epilepsy surgery or tumor surgery and preparing to prognosticate on how much language will be lost. Such situations you will use that. Then of course you can use the EEG, you can use the fMRI and intracarotid amyloid test. In this patient, I think you might have used the illuminoscope and the dominant thumb points and to find out the handedness. Yes. Next, you told that here deviation of mouth to the right side since 3 days.
Yes, ma'am.
So would you like to tell me the muscles which keep the angle of the mouth in balance?
Yes, ma'am.
What are the muscles that are involved?
Orbicularis oris.
Yes, so you have got orbicularis oris, then?
Buccinator.
So around the mouth, we have got orbicularis oris, rhizorius, zygomaticus major and minor, and depressor angular oris and mendalis. So these are the muscles which maintain the angle of the mouth in position. One is orbicularis oris, which closes the upper lip and the lower lip together, and this is maintained in horizontal plane by rhizorius. And the upward deviation is taking place by zygomaticus major and minor, and downward by mendalis, but they balance. So zygomaticus major and minor balances with the mendalis, so it remains in alignment. We use more of zygomaticus when there is a smiling, and we use more of mendalis when there is a expression of sadness. And this diplomatic smile, which does not carry any emotion, is by rhizorius. So these are the muscles. So when somebody is telling you that my angle of the mouth is deviated to the right side, yes, that indicates what? In the horizontal plane, apparently, I think, from what we have presented, no? Yes, so what muscle is imbalanced between both sides?
One would be the zygomaticus on the right side is over.
Yes, he didn't tell us about the vertical mall alignment, no? From the history.
Yes, sir.
From the history, the mall alignment is for horizontal plane. It is deviating to the right side. Yes, that means he is not able to maintain the angle of the mouth in alignment in the horizontal plane. Yes. So we will think whether it is a motor involvement involving the rhizorius. Yes. Zygomaticus or depressor or mendalis will produce upward or downward deviation, which patients may not be able to tell us. We will have to examine and find out. So it is mall alignment of rhizorius, or is it, what are the situation you will not be able to. So next question you will ask, is it present all the time? Is it present when you are resting? Is it present when you are smiling? Or is it getting corrected in any of these phenomena? So supposing the patient says that when I am smiling, it is disappearing, madam. No? Then what you will think? So that question is very important. Is it motor? Is it emotional? Or is it both? Yes. So next question you will ask, there is an imbalance in the horizontal plane. It can be motor, it can be emotional, or it can be both. So what happens when he is trying to smile emotionally? Is it persisting?
Emotionally, the patient will be able to smile normally. There will be no deviation, ma'am.
In this patient, what was the thing?
In this patient, I didn't ask for
We
this
got
one.
to ask, no, because it's a very important clue. Because you get pure motor paralysis or pure emotional paralysis in upper motor neuron disease. Whereas in lower motor neuron disease, if there is dissociation is there, if the patient says when somebody is joking or doing things like that, my deviation is disappearing. Then you don't, even though the weakness is not there, it may be a small lacune in the upper motor neuron pathway of the facial nerve. So if the patient says when I am smiling, it is all right. That's a very important clue. But if he says it is there during smiling as well as it is there during rest and during voluntary non-emotional smiling, then it means that it can be EMN, it can be LMN. It can be both. So in the LMN, it is always combined. Both emotional and motor fibers will be invariably involved in LMN. But in EMN, it can be combined or it can be dissociated. If the person says a dissociation, that is a very important clue. It may be a subtle upper motor neuron disease and may not be a LMN palsy. So when they say this deviation, we will ask these questions. So this is a deviation. We are not sure whether the emotional fibers were spared in this patient or not. So at this point, for the sake of theory, you would like to discuss the supranuclear motor control?
Yes, ma'am.
Supranuclear motor, emotional control. Is there any other supranuclear function for the facial, ma'am?
Supranuclear.
Blink. You see 3.
Blink.
So at supranuclear level, 3 functions are there. One is motor, second is emotional, and third is blink. I blink. No, it is also using the orbicularis oculi only, but it is another circuit. So in the supranuclear level, these 3 things are there. Yes. So which one you want to start with? Motor?
Motor, I will start with.
Yes. From where does it start, ma'am?
So we have the corticonuclear fibers or the corticonuclear fibers. So the representation is the fibers like always for any nerve, the nucleus, the representation is on the opposite side, opposite hemisphere. Yes. So if you take the nucleus, if you take the right-sided nucleus, it has the entire motor supply from the left side of the face, left half of the face. Along with that, it gets one backup of the upper part of the face to the ipsilateral side, ma'am.
We will say that the cortical control, if you want to tell in simple terms, yes, it is in the precentral area. It is in the motor area. Yes, the face by homunculus is inferior.
Inferior.
So it is in the inferior part of the precentral area. Yes. Face is represented there. And fibers which are subserving the upper part of the face have bilateral control.
Bilaterally represented.
Yes. And the fibers which control the lower part of the face are contralateral. So the cortical center for the facial muscles is in the precentral gyrus, inferior part. Inferior part of the precentral gyrus. The fibers for the upper face is bilateral representation and fibers for the lower face is contralateral. Then as you said, they descend along the corticonuclear fibers and they enter into the pons. In the pons they cross. In the pons you have got a dorsal nucleus and a ventral nucleus. The dorsal fibers are controlling the just prenuclear. The dorsal fibers are controlling the upper part and they have bilateral. So the fibers which are concerned with bilateral in the precentral gyrus, they settle themselves in the dorsal pons. Whereas the ventral fibers which control the contralateral side, they settle themselves in the ventral nucleus in the pons and they cross. They cross and land in the motor nucleus of the seventh nerve. So the prenuclear fibers start in the precentral gyrus, inferior part. The upper face fibers are bilateral, lower face fibers are contralateral. They descend like that just to reach the prenuclear part of the pons, where you have got a dorsal and a ventral component. The dorsal is the upper part bilateral, ventral is the contralateral. Then it settles down on the motor nucleus. The motor nucleus is having a special arrangement like the Warwick's model for the third nerve which we analyzed in the last class. For the seventh nerve, there are 4 nuclear groups. We call them as dorsomedian, then ventromedian, intermedius and lateral. So facial motor nucleus in the pons is in 4 components. Prenuclear fiber is dorsal and ventral. The dorsal is the bilateral part and the ventral is the contralateral part. Then it settles on the nucleus. The nucleus has got 4 groups. One is the dorsomedian, second is the ventromedian, third is the intermediate, and fourth is the lateral. Because each one is very uniquely localizable for us. So in the dorsomedian part is concerned with the occipital belly of occipitofrontalis and the auricular muscles. The ventromedian is concerned with the platysma. The intermediate is concerned with the orbicularis oculi, the nasal muscles, nasalis muscle, and the orbicularis oris. The lateral group is concerned with the buccinator mendalis. So each nucleus has got a specific. So you can tell this nucleus is degenerating in my patient by knowing by putting the muscles which are involved. You make a mathematical table, then you can definitely say it is a dorsomedial or ventromedial or intermediate or lateral. So in the nucleus, that is the unique arrangement. Then it goes round the 6th nerve nucleus, forms the facial colliculus. At this level, up to this level, it contains only the motor fibers. Then you have the descending limb. After the facial colliculus is formed, it is having the descending limb. In the descending limb, one nerve is joining, that is a nervous intermedius of Risberg. That contains the sensory fibers and the parasympathetic fibers. The parasympathetic fibers are for the lacrimal gland as well as the salivary glands. So they are the fibers which come from the lacrimal nucleus and the salivatory nucleus. They are concerned with parasympathetic function for lacrimation and salivation. Second group which is contained in this is the sensory fibers. So in the descending limb of the facial nerve, the nervous intermedius of Risberg is joining, which contains the parasympathetic fibers and the sensory fibers. So what is the relevance? In the motor level, in the nuclear level, if it is involved, it will be purely motor. So it will resemble Bell's palsy. The nuclear facial nerve, if the whole nucleus is involved, it will look like Bell's palsy. Bell's palsy is motor paralysis of the facial nerve without any accompaniments. So same thing will happen. But if the 6th nerve is also involved, it gives us a clue. It is not in the stylomastoid foramen, it is in the pons. Yes. Then in the descending limb, that is the intraaxial fascicula. The descending limb, it will involve the secretomotor fibers and the sensory fibers. So that is the use of when it is descending. Then it comes out through the ventral pons and enters into the petrous apex. The petrous apex lies in the Doral's canal. The petrous apex, it has got a canal which is called the Doral's canal. Then it enters into cerebellopontine angle, enters into the internal auditory meatus. There it keeps company of the 8th nerve and lies in the longest course in the facial canal. And in the facial canal, it gives rise to geniculate ganglion, from which the greater superficial petrosal nerve is given off. The greater superficial petrosal nerve will emerge through the superior-medial part of the petrous bone and comes laterally to the foramen lacerum, where from the internal carotid artery, the deep petrosal nerve is coming. And both of them join and they form the Vidian's nerve or nerve of the pterygoid canal. And that is concerned with lacrimation. So that is the first branch. Second branch is nerve to stapedius. So when the nerve is traveling through the descending limb of the facial canal, the first motor branch of the facial nerve is nerve to stapedius. It stabilizes the stapes. Then when the nerve comes down, it gives rise to the cauda tympani nerve. The cauda tympani nerve subserves, stays in the anterior two-thirds of the tongue. And then it comes out, leaves to the stylomastoid foramen and enters into the parotid gland. And just when it leaves through the stylomastoid foramen, the first branch is for the posterior belly of the digastric and stylohyoid. Then it divides into 5 branches. So first branch is the temporal branch, second that separates the temporalis, second is the zygomaticus branch, third is the buccinata branch, buccal branch, and fourth is the mandibular branch, and fifth is the cervical branch. So this is the motor pathway. From the precentral gyrus, it descends to the corona radiata, internal capsule, and in the you saw bilateral control for the upper part, contralateral control for the lower part in the inferior precentral region. Then pre-nuclear in the pons dorsal and ventral. The nuclear has got 4 components. For each group, they are separate, and it goes around the 6th nerve, forms the facial colliculus. Then in the descending limb, the nervous intermedius of Risberg is joining, which contains parasympathetic fibers and for secretomotor, and then it contains also the special sensory fibers and sensory fibers, comes out through into the cisternal space, lies in the petrous apex in the Doral's canal, enters into the internal auditory meatus along with the 8th nerve, and travels in the facial canal and geniculate ganglion. First branch is the greater superficial petrosal nerve, second is the nervus stapedius, third is the cauda tympani, and then it comes out and divides into 5 branches supplying the different muscle groups. That is the motor pathway. Second is the emotional pathway. So you have got an emotional smile, we have got a motor smile. The motor smile is, otherwise we call it as the executive smile, which does not carry emotion. So motor smile is carried through these fibers. At whatever level, it will help us to locate the pathology. Emotional fibers, from which part would you like to tell, Mom?
From the thalamus, no?
Yes. Emotional cortex, the thalamus is subcortex, no? Cingulum. You see, it comes from it has got multiple areas. One is the cingulum, second is the amygdala, hypothalamus, insular region, and then it descends into the motor nucleus and joins the motor nucleus. The emotional fibers come from multiple areas. One is the cingulum, supplementary motor area, hypothalamus, amygdala, and then descends into the motor nucleus in the pons. So that is the supranuclear emotion. That is why they are widely placed. So motor can be paralyzed alone, or emotion can be paralyzed alone. So if this differentiation is there, it is always upper motor neuron. Emotional fibers are alone paralyzed. Example, Parkinsonism. We call it as hypomania, because this supplementary motor area is one of the supranuclear control for emotional fibers. That is the cortical extrapyramidal system. Extrapyramidal system is cortical, subcortical, and spinal. So cortically originating extrapyramidal fibers come from area 6, that is supplementary motor area. So when that is damaged, you get emotional loss. So pure emotional facial palsy is upper motor neuron, whereas lower motor neuron is always combined. So because this emotional and the motor pathways are widely separated in the upper motor neuron. In the lower motor neuron, they are together. And third supranuclear I told is the blink. So in the supranuclear, you have got 3 functions. One is the emotional, second is the motor, third is the blink. So we now trace the motor, we trace the emotional, and then where is the blink? It is said that there is a second motor area, which is in the temporal lobe. It is called Crosby's area. Second motor area or Crosby's area. Crosby and Snyder. These are the 2 people. So they said blink is a bilateral facial activation at the supranuclear level. It is supposed to be a natural phenomenon to give mental rest. So when you have been continuously reading, a blink comes and it gives you some mental rest. But wink is a unilateral blink, which is a learned phenomenon. So unilateral blinking is not there in the default. it is a acquired motor activity, and blink is bilateral. So supranuclear, now you know the motor, pure motor where it is, blink where it is, that is in the temporal lobe, crosspiece and Sneeder's area, otherwise called second motor area. And third is the emotional, which is cingulum, supplementary motor area, amygdala, hypothalamus, and then descends into the motor nucleus. So they all converge into the motor nucleus in the pons. From pons, they cross over to the opposite side, and the pathway we traced up to the periphery. So that is the supranuclear aspect. So now your patient has got both motor and emotional, maybe.
Yes.
Now, did he ever say that when he was smiling, this face is becoming corrected?
No, ma'am.
He did not say.
He did not say.
So probably it is a combined one.
Right.
We'll presume it is a combined one. So upper motor neuron can be dissociated, can be combined. In the lower motor, it is always combined. We don't know because patient is unable to tell. So what we found, there is an imbalance between the rhizorius of right side and the left side, and even including the emotional fibers are involved in the deviation. So it's a combined facial deviation to the right side. So left side, there is a combined paralysis of both emotional fibers and the motor fibers probably. Second symptom you told is the slurred speech.
Yes, ma'am.
So, slurred speech, you clearly told that it is for labial. So probably the slurred speech is due to involvement of the orbicularis oris. So from the deviation, we thought rhizorius is involved. And from the speech, we think that orbicularis oris is involved. And the third point, you told that your patient has got difficulty in closing the eyes. So which is the closing muscle, which is the opening muscle? Difficulty in closing. Previous class which you presented, it was difficulty in opening.
Opening, yes.
No, so the opening muscle is levator. Levator is supplied by the third cranial nerve. Whereas closing muscle is orbicularis oculi, and you also have the Muller's muscle that we discussed in the last session. So Muller's muscle is also a closing muscle which is present in the upper eyelid and the lower eyelid, and you have got an orbicularis oculi. So in this patient is unable to close the eye.
Yes.
That means the orbicularis oculi is probably weak. Like unlike the previous class which was the levator, now this is an inability to close. So orbicularis oculi is weak. So far from these symptoms, we find that rhizorius, orbicularis oris, and orbicularis oculi. Three muscles are involved. Then he is able to blow his cheek up and blow the spit out. All those things, are they all right?
No, ma'am. It was also reduced. He was not completely able to blow out. He felt some weakness while trying to blow out.
So which is the
food also he did not have to. He was having inability to hold the food while eating. So and while having water in the mouth and all, he used to find dribbling also noted.
So what are the muscles which are interfering with the food coming into the floor of the mouth? Buccinator. Buccinator is the muscle which helps the food in the gingival pouch to come to the floor of the mouth. So if the food is not coming from the gingival pouch to the floor of the mouth, buccinator is the next muscle. But the drooling from the side can be explained by the orbicularis oris. Oris itself. Oris is the closing muscle. It is not closing the mouth. So food is drooling. So now we know that from the history that patient has a combined motor and emotional paralysis, and this seems to involve orbicularis oris, buccinator, orbicularis oculi, and rhizorius. So all these muscles, whether the platysma is involved, whether the depressor zygomaticus nasalis, patient is unable to tell. So if you so it's a combined paralysis. So now we want to know whether it is EMN or LMN. For that you told that your patient did not have any long tract involvement. Yes, it is not there. He is unable to tell us the history that he is unable to wrinkle the forehead. Yes. That we have to examine and find out. So from the history, there is a combined paralysis. It can be human, it can be element. We don't know, because in the human also it can be combined. And apparently the movements which are carried out by orbicularis oculi, buccinator, rhizorius, and oris are involved. Only this much information, and conclusions we will make after examination.
Yes,
and you told that taste is not affected. Patient does not have any excessive tearing. Patient does not have any excessive hearing. So excessive or reduced tearing, or does he have any hyperacusis? Does he have any loss of taste in the anterior two-third of the tongue? Those points our patient is not able to tell us. So we will keep it under abeyance. And at this point, for the benefit of everyone, would you like to differentiate upper motor neuron from lower motor neuron? All the points, including examination. That will become a table. No?
Okay, ma'am. Upper motor neuron, it can be either volitional or emotional.
Or both.
Or both.
Yes.
So upper motor, pure motor would be involvement of the emotional fibers would make it just above the at the level, like you told, the cortical level or subcortical level, ma'am.
So upper motor neuron, lower motor neuron, you put two tables. Upper motor neuron can be dissociated, whereas lower motor neuron cannot be dissociated at all. Upper motor neuron always need not be dissociated, but it can be dissociated. But in the lower motor neuron, it is always combined. It can never be dissociated in the lower motor neuron. That is the first point. Second point, which you always tell, wrinkling of the forehead.
Wrinkling of forehead is paired in upper motor neuron.
In upper motor.
Whereas lower motor, there is involvement of the entire face, ma'am.
Yes. So second point is, in upper motor neuron, the upper part of the face is paired. In lower motor neuron, it is both upper and the lower part, unless it is a branch involvement. Branch involvement can occasionally happen in infiltrating lesions of the parotid gland or conditions like Hansen's disease, where the terminal branches. So if the temporal branch is spared, you may have a apparent sparing. It's not a true sparing. But in lower motor neuron, there is no specific sparing of the upper part. It is a whole facial. Third point.
UMN usually will be associated with the long tract signs that may be present.
Yes. Long tract sign involvement is a point in favor of UMN. In LMN, it is not there. And next point. Involvement of greater superficial petrocell nerve to stapedius and the caudate
again,
yes, it is LMN. In UMN, this does not happen. Then fifth point, Bell's phenomena.
Bell's phenomena.
Yes. So what is Bell's phenomena? Bell's phenomena is seen in LMN. Bell's phenomena is not seen in UMN. So what is Bell's phenomena?
Upon attempting to close both the eyes, there is incomplete closure of the affected eye with uprolling of the eyeball on the affected side.
Yes. Uprolling. So uprolling will be more on the affected side in LMN. It will not be there in UMN. Why? Would you like to tell me why? If you remember why, then you remember it easily. Uprolling of the eye is carried out by which muscle? We studied in the last class. Now everything is clubbed only. Yes. It is superior rectus or inferior oblique. Whereas closure of the eye is orbicularis oculi. Orbicularis oculi is applied by seventh nerve. Whereas superior rectus and inferior oblique is applied by the third nerve. Two different cranial nerves. But how are they linked? There is a normal uprolling of the eyes with eye closure. Normally, when you close our eyes, all of us, there is an uprolling. So these are called as what kind of movements? Synkinetic movements.
Synkinetic.
Yes. When we walk with our legs only. But we swing our arms. So that is a synkinetic movement. So when we close our upper eyelid, but the eyeball rolls up. So they are called synkinetic movements. Whenever a particular movement is carried out, some other movements get linked into that. They are called synkinetic movements. So there is a physiological synkinesis between the eye closure and the uprolling of the eyeball. Here you have a situation where the eye closure is paralyzed, but the Uprolling is preserved because it is applied to the third nerve. So in LMN, there is muscle paralysis. In UMN, there is movement paralysis. I always insist on this point. This will be applicable at every level. So in UMN, there is movement paralysis. But when there is a muscle paralysis, there is a principle called principle of yoking. Yoke. So in these yoked muscles get equal amount of energy. So orbicularis oculi and superior rectus and inferior oblique get 4 ATPs, let us imagine. With 4 ATP, orbicularis oculi, which is paralyzed, will move little. Whereas superior rectus and inferior oblique, it is like the rope pulling from both sides. These competitions used to be done. No? Yes, so the superior rectus and inferior oblique will pull the eye much more than what the orbicularis oculi can do with the energy that is supplied. Yes. So actually, it is not the visibility of the uprolling. It will be exaggerated uprolling because of the mismatch at the LMN level. Whereas in UMN level, it is a movement paralysis. There is paralysis of the closer of the eye movement, and it has nothing to do with any synkinetic movement in the third nerve. So this will not be seen. So Bell's phenomena is due to loss of physiological synkinesis between the orbicularis oculi and the eyeball elevator muscles, which are yoked in that movement. In LMN, muscle paralysis, so one group of muscles become more powerful when the same amount of energy is supplied. Whereas it is not applicable to UMN because there is no muscle paralysis, there is only movement paralysis. So these are the points to differentiate LMN and UMN when it is unilateral. Second question, because we are going to apply all this when you examine the patient. So second thing is, when it is bilateral. When it is bilateral, how you will differentiate?
Bell's phenomenon might help us in both.
So Bell's phenomenon is not going to help you. When it is bilateral LMN or bilateral UMN, it will be symmetrical. Only when it is asymmetrical and one eye rolls much more than the other eye, it is going to tell us it is LMN on that side. So when it is bilateral LMN, bilaterally it will roll. It will be rolling partly. So it will be not going to show any difference between both sides. So Bell's phenomenon is not going to help us. Upper part of the face pairing is not going to help us. Because when it is bilateral, upper part also will go. So what are the things which will help us is, one, if there is a dissociation between emotional and motor, it is always UMN. Parkinsonism, bilaterally they have decreased expression. So if there is emotional and motor dissociation, it is always UMN. Second, if there is involvement of taste, stapedius or cauda tympani, it is always LMN. It is not at all UMN. Third point, facial reflexes will be depressed in LMN. You do the corneal reflex, conjunctival reflex, that will be depressed. Whereas facial reflexes will be exaggerated in UMN. Okay. And patient may have a pseudo-bulbar affect. Poor control of emotions in UMN. It will not be there in LMN. And presence of long track signs, as you said, ALS, bulbar pulses, they will have bilateral exaggerated reflexes. So these are the points to differentiate bilateral LMN and UMN. Here the Bell's phenomena and the upper face is not going to help us. When it is bilateral, the upper face pairing and the presence or absence of Bell's phenomena is not applicable. So that is how you differentiate bilateral LMN and bilateral UMN. So now we will go on to examine this patient.
This is a middle-aged male, conscious, cooperative, well-oriented to time, place, and person. On examination, blood pressure was 134 by 76 millimeter of mercury in the right arm supine posture, and pulse was 76 beats per minute, regular, normal volume and character with normal vessel wall, and peripheral pulses being well felt with no radial or femoral delay. Coming to the head-to-toe examination, there was no pallor, ectocyanosis, clubbing, lymphadenopathy, or edema that was noted. There are no neurocutaneous markers. The angle of the mouth was deviated to the right. There are no vesicles or skin lesions over the face, ear, or the throat. Ear examination showed no lesions over the pinna or external auditory canal. The tympanic membrane appeared normal and the normal cone of light was visualized. Coming to the nervous system examination, the higher mental functions. The patient is conscious, alert, cooperative, well-oriented to time, place, and person. Memory, immediate, recent, and remote are intact. Intelligence is normal. Language is normal. Speech, there is a dysarthria, and it involves the labials. Lobar functions were normal. Coming to the cranial nerves, 1, 2, 3, 4, 6, and 5th nerve are normal. Coming to the 7th cranial nerve, on the left there is loss of nasolabial fold. There is loss of wrinkling that is noted on the left side, and is unable to raise the eyebrow. And there is weakness of the buccinator, and the Bell phenomenon is present. However, the taste appears normal on the left side.
How do you test taste, ma'am?
To test the taste, we take paper that is showing a salt, sweet, sour, and bitter taste, and take the objects of a sugar, a salt, respective taste objects. And initially, we hold the tongue with the help of a gauze, and we place these objects one by one. And the patient is supposed to identify the paper which contains this particular taste that he feels.
What you have to tell is, that is correct. You have to tell the tongue is put out, tongue is dried. No? And for the anterior part of the tongue, mainly it is posterior part is metallic taste, anterior part is sweet and salt, and sides are sour. So you have to use it in the liquid form. And the drop should not cross the midline. So what are the principles? One part of the principles you told, because patient cannot speak, he will point. But you have to bring out the tongue, dry it, and apply the solution apply the material in the solution form, liquid form, a small drop, so that it does not cross the midline. So these are both aspects you have to, how he is pointing out is important, but how do you test is also important. Then how will you test the lacrimation, ma'am?
Should ideally do a Shermer's test for lacrimation.
Yes. How do you do that?
Ma'am, we take the Shermer's strip that is available, ma'am.
Yes.
So we place the strip bilateral in the eye, and we look for the rate of wetting of that tear strip, ma'am.
Yes.
Much as that. Is there any obvious inequality in between both? And what is the millimeter that is there, and the rate at which it appears?
So you can use a 5 millimeter ordinary filter paper. Instead of the validated Sherma strips, you can use a 5 millimeter filter paper and tuck it to the lower eyelid. And if there is no spontaneous tearing, you can stimulate tearing by tickling the nose and wait for 5 minutes. And normally the tear column is 1.5 centimeters at the end of 5 minutes.
5 minutes.
In a 5 millimeter filter paper. But that is okay. Due to various reasons, you can have dry eyes. Not necessarily due to paralysis of the greater superficial petrosal nerve. You can have cirrhosis due to vitamin A deficiency, or if you are exposed to irritant atmosphere. So what we check is compare both eyes. Put it on both sides. If it is asymmetrical, that points to abnormality. If it is symmetrical, need not be 1.5 centimeter all the time, because external factors will act on that. So that is modified Shermer's test. You need not buy the patented and costly Shermer's strip. It can be done. How are you going to ask about nerve to stapedius?
We can ask if he had any hyperacusis. He feels one.
Sound intolerance. So you have got in the laboratory an electrophysiological test called stapedial reflex. That's okay. History-wise, patient will tell, I am not able to tolerate sound. So hyperacusis is complained of as sound intolerance, irritability to sounds which the patient used to tolerate before. Noise is always irritating to our ears, but a normal sound becomes irritable means he feels it more. So you ask whether the person has got sound intolerance. If sound intolerance is there, then of course you can confirm it by stapedial reflex. So this is how you test all those things. All of them, according to patient, did not have sound intolerance, and he did not have any abnormality in tearing. Is it so?
Yes, ma'am.
Yes. Next one. Taste also normal.
Normal.
So would you like to trace the cauda tympani nerve? Superficial petrosal nerve we traced.
Yes,
That it is given off in the petrous bone in the superomedial surface, enters into the foramen lacerum, goes to the foramen lacerum, joins with the deep petrosal nerve and forms the nerve of the pterygoid canal or the Vidian's nerve. And now to stapedius, of course, it is given in the descending limb of the facial canal. There is no complexity. It lies among the labyrinth and goes and supplies the stapes. Yes. Then what about cauda tympani now?
It is related to the medial wall of the ear when the nerve is passing through, ma'am. So there it takes the second turn, the second bend that it takes, and it's related to the medial and posterior wall of the ear, middle ear. There it gives one branch that travels anteriorly, which is the cauda tympani branch of the facial nerve.
Yes, cauda tympani branch as it reaches the anterior two-third of the tongue. What are all the functions it does now?
It carries the taste sensations in the anterior two-thirds of the tongue, ma'am.
It has got not only taste, it also carries some somatic sensations. Okay. The fibers which carry the somatic sensation enter, that is called a hitchhiking. It enters into the lingual branch of the fifth nerve. Okay. And it goes into the spinal tract of the trigeminal, chief sensory nucleus, and ascends along the trigeminothalamic to the somatic sensation. Okay. Touch is also carried like that. Whereas the special sensory fibers goes into the nucleus of the tractor solitarius and ascend and goes to the insular region. So sensory fibers from the cauda tympani are both the special sensation for taste and somatic sensation. Special sensory afferents relay in the nucleus of the tractor solitarius in the pons, whereas and go to the and travels as the gustatory fillet to the insula, whereas the somatic sensory fibers, they go to the lingual branch of the mandibular division of the fifth nerve and then goes to the spinal tract, then ascends as the spindothalamic tract to the thalamus and sensory cortex. So that is the taste fiber, cauda tympani. Okay, go on.
The 9th and 10th nerves are normal. Palatal movements are equal and present bilaterally. 11th cranial nerve was normal. There is no weakness of the sternocleidomastoid. 12th cranial nerve was normal. Motor system examination. Coming to the examination, the arm circumference, forearm, thigh, and calf. There is no obvious wasting or differences between both the sides. Coming to the tone was normal bilaterally in the upper limb and the lower limb. Power was normal. There's no motor weakness. Reflexes, corneal and conjunctival reflex, abdominal, superficial and deep reflexes were present bilaterally. Coordination was normal. There is no involuntary movements. The sensory system, the sensations were intact. The spinothalamic and the posterior column sensations. There are no evidence of any cerebellar dysfunction. There are no signs of any meningeal irritation. The gait was normal. Skull, spine, and carotids were normal. Other system examinations were normal, ma'am.
Okay. Another area that the sensory supply for the facial nerve is a small area which is usually not symptomatic. It is the external auditory canal, auricular branches. No? So, but generally it is not symptomatic. Apart from the cauda tympani, it is having a small supply of sensation to the external auditory canal. So now you have a patient who does not have any long tract involvement. He is having upper facial, lower facial involvement. Other secretomotor fibers and the sensory fibers are not involved. So it looks like a pan-facial motor paralysis with emotional loss on the left side.
Left side, yes.
You said it is 3 days duration.
Yes,
so because did you elicit the corneal reflex and the conjunctival reflex, ma'am?
Yes, ma'am. Elicited, ma'am. I couldn't notice any difference in both the sides in the corneal and conjunctival reflex.
You are expecting it to be depressed because the afferent is the 5th and different is the 7th. You are expecting it to be, you have to make a photograph. Then you will see how much is the degree of blink which is elicited by corneal or conjunctival touch. Conjunctival touch can be reduced if they are manual laborers and exposed to dust particle. So conjunctiva may be less sensitive in physical laborers, but cornea will be very sensitive, but you should be very careful because patients can develop corneal aberration even otherwise due to defective eye closure, and you are not supposed to create any injury. But if you are having still doubt what is happening, is it LMN, purely motor, is it at the nuclear level? If you are thinking syringobulbia or a small lesion in the pons, purely motor, I said if 6 is involved, it is helpful. If it's not involved, it doesn't help us. So you are very suspicious, means you have to do the corneal reflex, not the conjunctival reflex. That you can use a wet gauze.
Okay.
That will be non-traumatizing. The dry cotton can be traumatizing. Wet cotton will be non-traumatizing. It is more sensitive. Conjunctiva, if you stimulate, you may get no difference because he is probably a laborer, wandering laborer, and his conjunctiva may be suffering from chronic dust irritation. Whereas cornea will be more sensitive, but you have to be careful not to do harm. So that you have to elicit. Now you said that this person's problem is only 3 days old, he is telling.
Yes, ma'am.
How will you know whether it is a chronic or short duration? So it's a pure motor paralysis of the facial, combined motor and emotional. Pure motor, combined emotional and motor can be at the level of the stylomastoid foramen. It can be at the level of the motor nucleus, or it can be upper motor neuron, for which we use the reflexes, corneal conjunctival reflex in this case, which did not help us. That's okay. So now you tell me that because we didn't do it in the cornea. Next you tell me, how you know it is only 3 days? If the person, what if the patient had a facial palsy in childhood? He has come from Bengal or Calcutta, you told, and he wants to go home and he gets an excuse from the employer. Then how we will know it is a chronic facial palsy? It's not a 3 days old facial palsy.
If it is chronic, the opposite side muscle, there will be
correct.
There will be the chronic contraction of the opposite side muscle will be more, ma'am.
So it will be manifesting as contraction of the paralyzed muscles.
Paralyzed muscle.
So instead of deviation to the normal side, it may be ipsilateral deviation. Ipsilateral. So chronic facial palsy, ipsilateral deviation. Then how do you know that it is not facial palsy on the other side?
We'll test for the weakness in the muscle,
so you'll check
power of the muscles, individual muscles.
So you will find that there is ipsilateral deviation with reduced power. So ipsilateral deviation with reduced power on that side. So if it is due to paralysis of the opposite side, the power should be not reduced.
Not reduced.
So because the power is reduced and ipsilateral deviation, you know it's a chronic facial. Second, you told about nasolabial fold. Nasolabial fold will be less prominent in an acute paralysis. Whereas in a chronic paralysis, it will be prominent due to the cutaneous contracture. So ipsilateral deviation with reduced power. Second, prominent nasolabial fold, and palpebral fissure may be in fact narrow. Instead of becoming wide. And then you can have features of hemifacial spasm.
Okay.
A partially damaged facial nerve can lead to twitching, movement, irritative phenomena. So presence of hemifacial spasm indicates it's a chronic facial. Then you may have evidence of faulty reinnervation.
Yes, ma'am.
Like crocodile tears.
Crocodile tears.
Or Marcus Gunn phenomena. So crocodile tears is because of the fifth nerve trying to repair the motor component of the seventh nerve. So whenever the motor fibers of the fifth nerve are put into action like chewing, fifth nerve supplies muscles of mastication. So when you try to do mastication, the greater superficial petrosal nerve becomes activated. Because greater superficial petrosal nerve is being repaired by the fifth nerve. So that results in crocodile tears. Why we call it as crocodile tears? It is said that when the crocodile tries to eat the other animals, it will cry, it seems. It will shed tears. So it is crocodile tears. So that is due to faulty re-innervation attempted by the motor fibers of the fifth nerve, and it gets trapped into the greater superficial petrosal branch of the seventh nerve. Then whenever the mastication is happening, tears will come. Then you have jaw winking or reverse jaw winking. Both can happen. When you open the jaw, opening of the jaw is by the pterygoids. So when the pterygoid are put into action, the motor fibers, like greater superficial petrosal is getting re-innervated, you get excessive tearing. When the orbicularis oculi is re-innervated by the motor fibers of the fifth, you can get a jaw winking. So these phenomena, if you find, you know that it is not 3 days, it's a very old facial palsy. Then for completion's sake, would you like to tell subtle facial palsy? Subtle, very subtle.
In subtle facial palsy, a very minimal weakness of the orbicularis oculi we'll have to examine. Ask him to close the eyelids tightly and then look for the tone or the power in the eyes.
Yes, you can look for the power of the orbicularis oculi. You can look for the blink rate. The blink will be reduced on the side of subtle facial palsy. And you tell the patient to screw the muscles and look for the burying of the eyelashes. It's very useful. As you said, the closure may be there. It may not be inability to close, but the power may be less. Second, the blink can be reduced. And burying of the eyelashes. When you screw properly orbicularis oculi, the eyelashes can be completely buried. If the eyelashes are jutting out on one side, that is a subtle facial palsy on that side. Then you have got some other test called Barbara-Wartenberg test and von Graeff's sign. What is Barbara-Wartenberg test is normal orbicularis oculi. Even though we think you are resting your orbicularis oculi, there's a subtle movement because eyeball is moving. You are scanning the environment. So you can ourselves put our fingers on the orbicularis oculi and see. A fine curing movement will be there.
Okay.
You can put and see. Fine tremulousness will be appreciated. Fine, very fine movement.
Yes, ma'am.
That is less on the side of paralysis. That is called Barbara-Wartenberg sign. Then there is one von Graeff's sign. You put multiple writing reflexes. So put your neck flex. So you have got body writing reflex, body on neck, the neck on head, head on orbit, orbit on eye. So many writing reflexes are put. The mild weakness will be brought out. So we tell the patient to flex like this and slowly raise the head. Then the asymmetry in the palpebral fissure becomes visible. So mild asymmetry. It may not be there in the straightforward resting. When he puts like this and brings it, that is called von Graeff's sign. Some other von Graeff's sign is also there. This is von Graeff's sign for subtle facial palsy. So these are the points by which you detect subtle facial palsy. So now we have a patient who is having a pure motor combined paralysis of the facial muscles on one side and which is not having any exaggerated facial reflexes. So we will take it as depressed. Even though you said you are not able to elicit a depressed reflex, maybe you checked on the conjunctiva, but it is not brisk. You can check the glabella, tapana, it is not at all brisk. So this can be either at the level of the nucleus, motor nucleus, or at the level of the stylomastid foramen. The points to differentiate, at the level of the motor nucleus, one thing you can have associated sixth nerve. And it never happens at the level of the stylomastid foramen. And the second point at the level of the nucleus is, I told you that there is a ventromedian, a dorsomedian, intermediate and lateral group. So each nuclear group can be separately involved, not all the muscles. Typical example is M&D, motor neuron disease. That is the one where the nucleus of the facial nerve gets degenerated. Not the M&D facial palsy is not at the stylomastid foramen. It is at the nuclear level. So only buccinator may be weak. So because each one is supplied by a different nucleus in the facial nerve. So nuclear level, the groups of muscles involved will respect the ventromedian, dorsomedian, intermediate or lateral group, which is degenerating at one point until the disease becomes end stage. So nuclear level, the muscles will respect the nucleus. Whereas in the stylomastoid foramen, the muscles will respect the nerve because it is the peripheral nerve where all the muscles are going to be involved. So these are and associated crossed hemiplegia, crossed pyramidal signs. If it's an intrinsic lesion in the pons which is involving the nuclear fibers of the seventh nerve, there will be subtle asymmetry or subtle pyramidal signs, even though it may be not expressed by the patient on the opposite side. So nuclear associated sixth nerve, then a nuclear pattern of muscle choosing and opposite side pyramidal. None of these things are there in your patient. No. So we will presume that it is involved not at the nuclear level, it is involved at the nerve level. So that has to be at the stylomastoid foramen. So you will describe at the end as a queer motor and emotional paralysis of the facial nerve on the left side involving upper and the lower part with no brisk jerks, with no other accompaniment. So it can be Bell's palsy or it can be nuclear facial nerve palsy. And because there is no associated sixth nerve, there is no nuclear pattern of muscle wasting, there is no contralateral exaggerated reflexes, I feel that it is Bell's palsy. So that's all you can tell. It can. Then you will have to do the nerve conduction and other things. To know nerve conduction will be abnormal if it is at the stylomastoid foramen. Whereas if it is at the nuclear level, only EMG will be abnormal. Nerve conduction will be normal because nerve is not affected. It is a nucleus that is affected. So then you have to say what is the cause. So we think it is probably a facial nerve paralysis at the stylomastoid foramen. And what could be the cause? What are all the causes?
Causes most commonly implicated recently is the HSV1 that is commonly implicated, ma'am.
Yes.
Apart from that, we can have retroviral disease that can have.
Yes.
Then
if you want to group down, you see, if you start enumerating the disease, no, in the human body, innumerable diseases.
Yes, ma'am. So we'll group it.
A short duration facial nerve paralysis at the stylomastoid foramen. It can be infective, inflammatory, traumatic, vascular,
and neoplastic.
Yes.
Neoplastic subacute.
Short duration, 3 days. So infective, inflammatory, vascular or trauma. Short duration stylomastoid foramen involvement is infective, as you said, herpes, retroviral disease, now even COVID, no?
COVID.
So many diseases. So infection, you said the evidence is lacking. Patient did not have any vesicular lesions in the ear or in the external tympanic membrane. To your capacity, you didn't see anything. Then other diseases, other viral infections, we don't know, we'll have to check. Now, you know, Bell's palsy is currently one important marker for COVID disease. So we don't know. So it can be infective, generally viral. Any bacterial infection? Never forget Hansen's disease.
Hansen's.
Yes, Hansen's disease will involve the branches. It doesn't involve at the stylomastoid foramen. So less likely to be infective of Hansen's nature because the whole nerve is involved and it will be partial. We have got one scoring system called Bachmann scoring of severity.
Okay.
Grade 0 to 4. 4 is complete paralysis of all the muscles is grade 4. 0 is normal. 1 is a subtle weakness which we elicit. I told you the points by which you detect the subtle weakness. So subtle weakness, Bachmann scoring. It is called Bachmann scoring. Subtle weakness is grade 1. Moderate weakness but still movement is there. It's grade 2. And between complete paralysis but flicker of no complete paralysis, some flickering is there. That is grade 3. And complete paralysis is grade 4. So if you want to put the grading for this patient, it is Bachmann's grade 4. Complete paralysis. No? Which never happens in Hansen's disease. It is always partial paralysis and it is branch. So infection, you are not thinking Hansen's. We should always think about that. You are not thinking Hansen's because it is Bachmann's grade 4 and all the branches are involved. So among infective, you can still consider infection as a possibility, but it is not Hansen's. Inflammation, conditions like Guillain-Barré syndrome.
GBS, Guillain-Barré.
Yes. Very common, no? Very common in that part of our country. So it is an inflammation associated with acute immunological disorders or chronic immunological disorders. Both it can happen, CIDP also it can happen. Even though 10th nerve is more common in CIDP, it can still happen. So is it possible? Other accompaniments are not there, so we don't know. Vascular. Trauma, history of trauma is not there. Vascular, you cannot rule out. Yes, your patient is a diabetic. So diabetes is a vascular cum metabolic disease. It's having a metabolic component, it has got a vascular component. The vasonervorum of the seventh nerve can be involved due to diabetes. So you do not know whether it is a vascular complication secondary to chronic diabetes or any other vasculitic disorder which clue is not there, diabetes is here. So these are the possibilities. So boil down, you will consider either a viral infection related or it can be vascular. So it is a Bell's palsy, short duration, and the etiology could be either infective or viral nature or it can be vascular because the person is a diabetic. So these are the possibilities at the end. So you can look for, you need not always give acyclovir to every patient. You see, it used to be recommended some 2-3 decades back. Now it is not recommended because it is not always herpes. It can be due to non-specific viral adenoviruses, cytomegalovirus, and all these viruses. Also, they do not respond to acyclovir. And in a diabetic patient, sometimes acyclovir can precipitate nephropathy. You know that, no? So you will look for other evidence of diabetic neuropathy. Is it there or not? If it is there, you may consider that as possibly a vascular component. Other features of diabetic retinopathy, all those things you can look for. If that, again, it will narrow the differential diagnosis. So would you like to tell me the diabetic complications on the, how do you categorize the diabetic neuropathy?
Pure sensory, pure motor, sensory motor, and diabetic amyotrophy.
Just when you take one case, we will repeatedly reinforce, so we do not forget. We have to think laterally, so that you make a novel diagnosis. It may be a novel case presenting as a facial pulse, we don't know. So diabetic neuropathy is distal symmetrical mixed neuropathy, that is the commonest.
Common one.
Second is asymmetrical proximal, that is diabetic amyotrophy. Then focal and multifocal. Under that you have got the cranial neuropathy. You can, even though commonly you get third nerve, you can get 7th, you can get 9th, 10th. So that is focal or ulnar nerve, median nerve, radial nerve, common peroneal nerve. That is focal and multifocal. So distal symmetrical mixed neuropathy, proximal asymmetrical neuropathy or diabetic amyotrophy, focal and multifocal neuropathies. Then uncommon varieties like purely autonomic. Patient may present with postprandial fullness, postural hypotension, dry skin. Other features may be not there. Bladder. So it may be purely autonomic. It may be purely large fiber also rarely. Or you can have CIDP complicating diabetes. C-peptide antibody. That has to be treated with cyclophosphamide. On diabetic retinopathy. So distal symmetrical mixed, proximal asymmetrical, focal, multifocal neuropathies, and uncommon neuropathies like autonomic neuropathies and CIDPs and retinopathy. So you look for all those things. If it is all florid, you don't have to find out another cause for this. It may be a mononeuritis of diabetes. So at the end, you have two causes as a strong possibility. Is it a cranial mononeuritis of diabetes, or is it a viral induced facial palsy at the sternum? So how are you going to treat, ma'am?
Usually recommendation is short course of steroids, minimum
Yes.
at least for 1 week, 1 mg per kg should be given.
In the
Our
case of
steroids,
diabetes, you give a little more caution, you control the diabetes.
sugars.
Because the stylomastide foramen, it's an entrapment. With Bell's palsy, why you give steroid? Because it's an entrapment.
Inflammation.
When there is edema, the nerve gets entrapped. The nerve dies due to entrapment and compression rather than due to inflammation, which is self-limited. The inflammation is self-limited, it may go off. But because of the entrapment in the foramen, nerve fibers might undergo permanent damage. That is why you give steroids. Short, high dose.
Yes.
Correct? Then acyclovir is not now uniformly recommended. It used to be recommended like that. If you have high degree of suspicion, if the patient had a contact with the person with herpes or chickenpox, then you can give, or you see the vesicles. Otherwise, it is not mandatory. Okay. Then third, you have to protect the eyes.
Eyes, so dark goggles.
Yes. So most important, you have to. So if it is a very severe, like grade 4, your people stitch up the eyes, upper eyelid and the lower eyelid, or it is temporarily sutured to protect the eyes, or you use goggles. Even if you don't need a refractive goggle, a goggle is given to protect the eyes. Then of course you prevent the stretching, loss of elasticity due to stretching, and permanent damage to the muscles is prevented by strapping the muscles. When you are doing physiotherapy, you do the physiotherapy. Rest of the time you strap the muscles. Okay. So this so you have to tell disease, real specific treatment if there is a viral cause, or non-specific treatment to protect the eyes and prevent excessive stretching and damage. So this is your case. So straightforward case commonly discussed, but still I think facial nerve is very important because it is your smiling muscle that makes you into what you are. We smile, we grin, all those things are expressed through the facial nerve. It's a very important nerve. Second, taste, very important. No? For survival, you have to taste your food. You have to speak out. So it is, even though it's a very simple nerve, it is a speaking nerve, it's a smiling nerve, and it is a tasting nerve. So it's very, very important for us. I think I carried you through the upper motor neuron. So here you can apply my template. I use one template of supranuclear, any cranial nerve, supranuclear, which may be cortical and subcortical. Second is nuclear, supranuclear, cortical, subcortical. Second is nuclear. Third is intraaxial vesicular. Fourth is cysternal. Fifth is skull base, foraminal, soft tissue plane. The Hansen's disease or parotid tumors, it gets involved in the soft tissue plane. So it will be the branches. So any cranial nerve, you make a mental template. What is supranuclear? Under supranuclear, you have got cortex and subcortex. Then you have got the nucleus. Each cranial nerve has got a unique nuclear arrangement. So that you will have to study. So nuclear, then it comes down intraaxial vesicular, then leaves the brainstem cysternal, then creeps in the skull base in the petrous apex, enters into the facial canal, that is a skull base, then foraminal stylomastid foramen, then soft tissue plane. So any cranial nerve other than the first and the second have all these planes. So you have to make a mental template, fit all these points into that. The books do not exactly give like that, but you make a template, it will be very easy for you to localize. Yes. So any doubts, ma'am? So you think that special nerve is still special, no? Yes.
So any reason why upper part of the face has bilateral innervation, ma'am?
The reason actually I am not knowing any explanation because it is like the blink, ma'am. Because you think, you wrinkle your forehead, which is considered to be having a higher cognitive function. Okay. So it is like the blinking, which is for the mental rest. So it is always bilateral. And wrinkling is for concentration. The wrinkling movement goes with the focusing and concentration. So that is having a supranuclear control different synkinesis associated with different mental functions. So it is probably the reason, I think so, but nobody knows, because it is ringling bilateral part, which goes with the higher cognitive activity rather than the routine smiling activities. Any other question, ma'am? Why is human there is no muscle paralysis? Because a muscle is an element structure. Muscle is a lower motor, because beyond the cranial nerve nucleus or beyond the anterior horn cell, all are element. Whereas before the nucleus of the cranial nerve and anterior horn cell, it is upper motor neuron. Upper motor neuron is like preparing the template for a house construction. So it prepares the motor schema. You see how I speak, so that I speak the names of my students or my parents, or I make a sing or anything. For that, schema is made. It has nothing to do with the muscles. Motor schema, the template is prepared by the upper motor neuron. This is how you have to move. And that command is converted into a muscle mediated activity. So muscle is an element structure, whereas movement is an element structure. Movement template is prepared by the upper motor neuron. The muscle template is carried out, it is like the laborers. Muscle is like the laborers, whereas template is like the engineer. So both are different. So that is why there is no muscle paralysis in upper motor neuron, only movement paralysis. Any other question, ma'am?
They've asked if we can explain the theory behind Bell's phenomenon. Again, they wanted.
Yes, I will tell. You see, Bell's phenomenon, that is another thing when we go, if you go in a pattern, we know Hess principle or principle of yoking. What is Hess? It's called Hess principle in physiology or principle of yoking. Any group of muscles involved in a particular activity are called yoke muscles. So any muscle which carries out a synkinesis. So there is a physiological synkinesis. As I told, it's a synkinetic movement between the third nerve innervated muscles and seventh nerve innervated muscles. It is like swinging the arms while walking. So we swing the arm while you are walking. That's a physiological synkinesis, but not much primary relevance as far as we know. So this is applicable to lower motor neuron. So muscles get yoked into a particular activity. So yoked muscles get equal amount of energy. Hess principle indicates any muscle yoked in a particular activity get equal amount of energy. So when ocular muscle and orbicularis oculi are yoked in a particular activity, when the command is to close the eye, you are given the command close the eye. When you close the eye, automatically orbicularis oculi and superior rectus and inferior oblique gets the same amount of energy. With the same amount of energy, as I have told, the classical example of rope pulling in temple festivals used to happen in our temple festivals. So if one is weak, the other will pull. You see, like that. Now, whenever the eye is closed, superior rectus has to move up. When both are in equal power, that is balance between both eyes. So both eyes move. Whenever the 5 degree eye closure, there will be 5 degree orbit elevation, eyeball elevation. 5 degree eye closure, 5 degree eyeball elevation. But now you have a situation where with 4 ATP, a weak muscle can slowly only move. So it cannot move completely. So it will partially close. But always it is taught that it is a visibility of the synkinesis. So the eyeball rolling up is symmetrical only, it is visible. That is how undergraduate teaching is done. But it is not. Bell's palsy is very common. You can see any patient. So this eyeball will roll up because it is like the rope pulling experiment where the superior rectus moves much faster and much more with 4 ATP, whereas orbicularis moves much less and much slower than what the superior rectus can do. So it's a mismatch in the ability to work between a normal eyeball elevating muscle and a paralyzed eyeball closing muscle. Is it clear?
Yes.
You can read in your physiology the principles of yoking, or it is called Hess principle, HESS. Yoking means what? Both muscles are involved in a particular activity. It is just like pulling from one side and pulling from the other side, the rope. And one is weak, so the weak side will be pulled towards the strong side. So here you have a situation where the yoking is between two nerve innervators. So it is very important in nerve paralysis, whereas it will never happen in muscle disease. Bell's phenomena happen in nerve paralysis because two nerves are supplying, one nerve is damaged, other nerve is normal. So the normal nerve will sit up. It is principle of Hess or yoked muscles in synkinetic innervation. Any other doubt, ma? Any other doubt?
No.
Because facial is a very common nerve, but it is a very important nerve because we smile with our facial nerve. So that is why the supranuclear emotional component, you have to not forget that at all. And when we examine, you have to specifically mention, as a postgraduate, we have to mention that. Anything else, ma? No. No. It is useful. Chandra is many times you would have heard Chandra classes.
Yes,
Still, it is interesting because it is a smiling nerve. It helps us to smile. So, once my teacher used to tell, somebody was reconstructing the facial nerve with the palmaris longus in Madras Medical College. He rotated the palmaris longus and reconstructed the risorius following a chronic facial palsy. One Sam GP Moses was a plastic surgeon in MMC. He reconstructed, and my teacher, he went and told him, smile is not in the LMN. Smile comes from, so you can never create the emotional component. You can only correct the grin part of it. The grin part of it gets corrected, but the emotions are never expressed. So it comes from the different aspect, the limbic, which I told, it comes from the amygdala and all those areas. So it was clear, huh? Any doubt is there, you can ask, otherwise you will close. Clear?
Very clear, ma'am. I don't think, even when you read facial palsy, and even though we keep seeing, but this amount of depth and the way you put it was very simplified, ma'am. Each level localization and the template. That is like very useful for like having a localization.
Thank you so much. When you are free, you inform. When I am free, I will inform. We can continue whatever you want. You just tell your chief, Dr. Kishan.
Madam, I'm also listening. I'm in student section. I'm not chief anymore. I'm in student section.
Thank you.
Learning from you. So, madam, whenever you free, please we'll have the classes. And all the students are very much interested. We are getting very good responses for your class, ma'am, especially. So please, ma'am, whenever at your convenience,
yes,
we'll have the classes.
I will keep informing whenever I am free. Otherwise, I think provisionally Wednesdays can be tomorrow, because today I have taken, tomorrow I will take off. But otherwise, I think Wednesdays, if you are free, you can put anything by your volunteers.
Okay.
Yes.
And just inform me. Otherwise, when there is a leave and I am sitting at home, I will inform. Today I took leave.
There is no leave at all then. Members, really, why she's a legend? Because today, ma'am only told us like a few days back, Kishan, I have taken a leave on Tuesday. Is it possible to take class? Who will care for us like this? This is what made her take her that level. Okay, she would have taken rest at home, spending some Onam time with Madam. By the way, happy Onam to you and your family.
Thank you.
My first Onam in
I will tell you some quotation. I enjoy more than whether you benefit or not. I enjoy more, without any doubt. So I thank Dr. Kishan and all the team for making some hours more pleasurable, even though I have retired. I am so grateful to you for this. Thank you so much.
Thank you. Thank you, ma'am. Thank you so much.
Thank you.
Vijay, Balaji, well done as usual. Okay, wonderful presentation. Okay, but yeah, how much good you do? There's a lot of still learning from madam. Okay, there's each point she makes it so clear for us. So lot to learn. Thank you so much for both of you.
Thank you. Thanks.
Thank you, ma'am.
For making this study so enjoyable. Thank you. Shravan, shall we end the session?